Welcome to the chemistry lecture on electrolytes part 2. Please read through the objectives on your own as we will begin today with the introduction on slide 6. To recap from Monday's lesson, the major electrolytes include sodium, potassium, bicarbonate, phosphate, calcium, magnesium, and sulfate. It's important to remember that although most of these circulate as free ions, calcium and magnesium are found primarily bound to protein. The three analytes we will be covering in this lesson are calcium, magnesium, and phosphates. In the body, there is about 1,000 grams, or 1 kilogram of calcium, 600 grams of phosphate, and 25 grams of magnesium. In bone, calcium combines with phosphorus to form hydroxyapatite. The table shown here gives a general breakdown of the distribution of these three electrolytes. When we look at the distribution of these three electrolytes in circulation, we find that about 50% is complexed or bound, and about 50% is free ions. Complexed means bound to organic or inorganic anions. For instance, calcium can complex with citrate, phosphate, lactate, and sulfate. Typically, when we measure calcium, we are measuring total calcium, but we can also measure free or ionized calcium. Phosphates can exist in three forms, as H2PO4, HPO4, or PO4. All three forms play an important role in the phosphate buffer system, but the system is mainly a ratio between HPO4 and H2PO4, which is around 4 to 1 at a pH of 7.40. The average adult body contains anywhere between 1,000 and 1,300 grams of calcium, 700 to 800 grams of phosphate, and 23 grams of magnesium. The daily requirements are straightforward: 600 to 800 milligrams for calcium, 800 to 1,400 milligrams for phosphate, and 300 to 350 milligrams for magnesium. There are two primary forces regulating the concentration of these three analytes: physiologic processes and hormones and vitamins. The skeletal system is the primary site for storage, particularly for calcium and phosphate. However, these analytes can also be pulled from the bones through a process called resorption when blood levels fall too low. Since the main source for replenishing these electrolytes is through the diet, intestinal absorption plays a critical role in regulating levels and can respond to vitamins and hormones. Renal excretion of calcium, phosphate, and magnesium has a direct effect on blood levels too. The same hormone that affects intestinal absorption also influences renal excretion. More on that in a couple of slides. Three hormones and vitamins play a role in regulation. These are PTH, also known as parathyroid hormone or parathormone, calcitonin, and vitamin D, or 1,25-dihydroxyvitamin D3. The biologically active form of vitamin D that stimulates calcium absorption in the intestines is 1,25-dihydroxyvitamin D3 and is synthesized by the body. Vitamin D production begins mostly in the skin from cholesterol-like substances. the main one being 7-DHC, or 7-dehydrocholesterol, and to a lesser degree, ergosterol. Exposure to sunlight, particularly in the ultraviolet spectrum, causes conversion of 7-DHC to cholecalciferol, or vitamin D3, and ergosterol to ergocalciferol, or vitamin D2. There are secondary or minor sources of vitamins D3 and D2 that also contribute to the overall process of vitamin D production. These include fish and meat, which contain vitamin D3, mushrooms, which contain vitamin D2, and vitamin supplements. Regardless of the source, though, both cholecalciferol and ergocalciferol are hydroxylated in the liver to 25-hydroxyvitamin D3, or calciferol, which then makes its way to the kidneys. The kidneys then hydroxylate 25-hydroxyvitamin D3, or calciferol, again to form 1,25-dihydroxyvitamin D3, or calcitriol. PTH, also known as parathyroid hormone or parathormone, is produced by the parathyroid glands, which lie on either side of the thyroid gland. PTH is produced primarily in response to decreased ionized calcium. It is also produced in response to a decrease in magnesium, especially if there is a rapid drop, and to an increase in phosphates. A decrease in phosphates is essentially the same as an increase in calcium, since they are inversely related. PTH acts on bone, the kidneys, and the intestines. Overall, it increases the blood levels of calcium and magnesium and decreases phosphate. PTH increases blood calcium levels by acting on the bone, increasing osteoclast activity, which increases resorption into circulation. PTH also acts on the kidneys by increasing the reabsorption of calcium in the DCT. Additionally, PTH stimulates the synthesis of the active form of vitamin D in the kidneys, 1,25-dihydroxyvitamin D3, which stimulates the intestines to increase absorption of calcium and phosphates. The main effect PTH has on phosphate levels is to cause them to decrease. This is the case because although phosphate is released during bone resorption, PTH decreases the reabsorption of phosphate in the PCT, causing an increased excretion in the urine. The overall net is negative for phosphates. Vitamin D responds to decreased ionized calcium levels by stimulating increased calcium absorption in the intestines. Vitamin D also stimulates absorption of phosphates in the intestines. In addition, vitamin D also increases reabsorption of calcium in the kidneys. Vitamin D can be absorbed in the intestines from dietary sources or synthesized in the skin by the action of UV light. Remember that vitamin D requires 2 steps to become biologically active. First, in the liver, it becomes hydroxylated at carbon 25. Thus it becomes 25-hydroxyvitamin D3. Second, in the kidneys, where hydroxylation occurs again, this time at carbon number 1, to produce 1,25-dihydroxyvitamin D3, which is the biologically active form. Calcitonin is produced by the thyroid gland in response to high blood calcium levels. It is antagonistic to PTH and reduces blood calcium levels by inhibiting calcium absorption in the intestines, inhibiting osteoclast activity, thus reducing resorption, and inhibiting renal reabsorption of calcium. The normal range for calcium, total calcium, is 8.6 to 10.0 milligrams per deciliter. The normal range for ionized calcium is 4.6 to 5.3 milligrams per deciliter. It is important to remember that when testing specimens for ionized calcium, do not remove the cap until right before introducing the specimen into the instrument, as ionized calcium drops dramatically upon exposure to air, resulting in falsely low values. This occurs because as CO2 is released from the sample, the pH increases, which will affect calcium albumin binding. When the pH increases, as in alkalosis, ionized calcium values will be falsely low. When the pH decreases, as in acidosis, ionized calcium values will be falsely high. This is because more hydrogen ions are available to replace the calcium bound to albumin, resulting in a release of the bound calcium to the ionized form. Remember, values should be interpreted in light of the patient's acid-base status. Next, we'll talk about measuring calcium. A total calcium will include calcium that is bound to proteins, complexed and ionized or free. However, only ionized calcium is biologically active, making it a much better indicator of what is going on with calcium. Plus, values are unaffected by protein levels. A very common method for measuring total calcium is the colorimetric method. Two of the most common dyes to use are arsenizo-3 and CPC, which is orthocresylphthalein complexome. Regardless of which dye is used, measurement of total calcium requires an acidification step to release protein-bound and complexed calcium. Otherwise, these two forms will not react. Of course, ionized calcium is typically measured by ISE. Acid-base disorders may result in variation in the amount of ionized calcium. It's important to remember, though, that even though calcium changes from one form to another, ionized or not, the total calcium remains the same. Calcium serves a variety of functions throughout the body. It is the major constituent of bones and also is essential for normal muscle contraction and conduction of nervous impulses. It plays an essential role in coagulation, being coagulation factor number 4. It plays a role in cell membrane permeability, is an enzyme activator, and activates complement components. Here are some fun facts for calcium. First, it is the most prevalent cation in the body. Next, has to do with protein. Serum protein levels tend to have very little effect on ionized calcium levels. However, for every 1 gram per deciliter decrease in albumin, total calcium drops by 0.8 milligrams per deciliter. Calcium also shares a relationship with phosphate. Serum phosphate levels are inversely related to serum calcium levels. Serum calcium levels are regulated by PTH, calcitonin, and vitamin D. PTH is secreted by the parathyroid glands in response to falling ionized calcium levels and has 3 primary effects. First, it increases osteoclast activity, causing breakdown of bone and release of calcium into circulation, or resorption. Next, it stimulates the kidneys to decrease excretion of calcium. And finally, it stimulates the kidneys to activate, through hydroxylation, vitamin D. Calcitonin is antagonistic to PTH. It is secreted by the thyroid gland in response to high serum calcium levels. Calcitonin acts to reduce calcium levels by inhibiting absorption in the intestines, inhibiting osteoclast activity, a decrease resorption, and inhibiting renal reabsorption of calcium, increased excretion. Vitamin D, of course, is essential for the absorption of calcium in the intestines. Just as with the other electrolytes, we'll be looking at conditions that cause increased and decreased levels of calcium, starting with the former. Hypercalcemia can be caused by hyperactive parathyroid glands, a condition called primary hyperparathyroidism, and malignancies that have metastasized to the bones. Together, these two disorders account for about 95% of all cases of hypercalcemia. Hypercalcemia usually does not have symptoms, but with very high levels can cause nausea and vomiting, excessive thirst, frequent urination, constipation, abdominal pain, muscle weakness, muscle and joint aches, confusion, and lethargy and fatigue. Critical values primarily alert the physician to the severity of the underlying condition. Hypocalcemia is most commonly caused by decreased protein levels, such as hypoalbuminemia, though ionized calcium levels may actually be normal in some circumstances. Conditions that may cause hypocalcemia include liver disease, nephrotic syndrome, congestive heart failure, and malnutrition. A less likely cause today is primary hypoparathyroidism, caused by accidental gland destruction or removal during thyroid surgery. Pseudoparathyroidism is due to cellular resistance to PTH, resulting in increased PTH levels. Hypomagnesemia can cause hypocalcemia because it decreases calcium absorption as magnesium plays a role in intestinal absorption of calcium. Steatorrhea impairs absorption of calcium at the intestinal level. If you're not familiar with steatorrhea, it is a condition that results from malabsorption of dietary fats. These fats combine with calcium in the intestines to form soaps through a process called saponification. These soaps typically cause diarrhea and other unpleasant gastrointestinal symptoms. Vitamin D is necessary for absorption of calcium in the intestines. Vitamin D deficiency in children causes a condition called rickets, while in older folks it causes osteomalacia. Ionized calcium correlates better with parathyroid disease as it is unaffected by albumin levels. In primary hyperparathyroidism, both PTH and ionized calcium levels will typically be increased, but the total calcium may be normal. Phosphate levels will be decreased. Primary hypoparathyroidism typically causes the opposite, along with a decreased total calcium. Next up is phosphate. In circulation, about 85% exists as inorganic phosphate, HPO4, or H2PO4, with a ratio of 4:1 at a pH of 7.4. and about 15% is bound to proteins. The normal range for serum and plasma is 2.5 to 4.5 milligrams per deciliter, or 0.81 to 1.45 millimoles per liter. Levels tend to be higher in children, 4.0 to 7.0 milligrams per dl, or 1.29 to 2.26 millimoles per liter. The typical sample is serum or plasma, but urine can also be analyzed. It is important to avoid hemolysis as it can cause interference. Measurement of phosphate is typically by colorimetry using a molybdate compound. Phosphates are a major component of bones and teeth and are also necessary for formation of 2,3-DPG, a necessary component for dissociation of oxygen from hemoglobin. Phosphates are also necessary for metabolism of carbohydrates, proteins, and fats. They are an integral part of cell membrane structure. They play a role in acid-base balance, being part of the phosphate buffer system. They are required for the formation of ATP, are involved in normal muscle and nerve function, and are a component of nucleic acids and nucleotides. To lower phosphate levels, PTH is released, which increases renal excretion. In addition, calcitonin inhibits bone breakdown and resorption. To increase phosphate levels, vitamin D enhances absorption of phosphates, and growth hormone increases renal tubular reabsorption. Remember, PTH has the opposite effect on calcium and phosphate levels. Hyperphosphatemia can occur in patients with renal failure due to a decreased ability to excrete phosphates, vitamin D overdose, hypoparathyroidism, and acute osteoporosis. Hypophosphatemia can occur in patients with hyperparathyroidism, decreased intestinal absorption due to malabsorption, vomiting or diarrhea, vitamin D deficiencies such as rickets and osteomalacia, and hypocalcemia, since decreased serum calcium levels stimulates release of PTH. The main symptom is mental confusion due to low ATP. The typical samples submitted for magnesium are serum and plasma, but urine can also be acceptable for testing. When testing serum or plasma, it is important to avoid hemolysis, since intracellular magnesium can cause falsely elevated values. Likewise, it is important to separate serum and plasma from cells as soon as possible. The normal range for serum and plasma is 1.3 to 2.1 milliequivalents per liter. So, imagine we have two patients' results that we are evaluating, but the units for one is in millimoles per liter, and the other is in milligrams per deciliter. The first patient's magnesium level is 1.0 millimoles per liter, and the second patient's level is 2.0 milligrams per deciliter. Are the results normal? Let's take a look at how to interconvert units used for electrolyte analysis. Let's start by looking at the first patient's results, 1.0 millimoles per liter. In order to determine if this result is normal or not, we either need to convert the normal range to millimoles per liter or convert the patient's result to milliequivalents per liter. Let's first start by discussing equivalent weight. The equivalent weight for any element, for example magnesium, is the amount of an element that will react with 1 mole of electrons, or, for example, 1 mole of chloride. The amount or moles of magnesium that will react with 1 mole of electrons, like chloride, is 0.5. Since magnesium has a +2 charge and chloride has a -1 charge, it will take half as much magnesium as chloride to reach a neutral charge when they combine. Thus, 1 mole of magnesium will react with 2 moles of electrons. You can think of it as moles of chloride instead of moles of electrons, to produce magnesium chloride. So, 1 equivalent per liter of magnesium is the same as 0.5 millimoles per liter, and 1.3 to 2.1 milliequivalents per liter is the same as 0.65 to 1.05 millimoles per liter. In that case, the first patient's result of 1.0 millimoles per liter is normal. Next up is the second patient who has a magnesium value of 2.0 milligrams per deciliter. We'll start with the atomic weight of magnesium, which is 24.31 atomic mass units. Therefore, 1 mole of magnesium is 24.31 grams. Therefore, 1 mole per liter is 24.31 grams per liter, or 2,431 milligrams per deciliter. Therefore, 1 millimole per liter is 2.4 milligrams per deciliter. And finally, therefore, the range is 0.65 times 2.4, which is 1.6 milligrams per deciliter, to 1.05 times 2.4, which is 2.6 milligrams per deciliter. So yes, it is a normal result because the reference range in milligrams per deciliter is 1.6 to 2.6 milligrams per dl. I have provided a handout on the interconversion of units for milliequivalents per liter, millimoles per liter, and milligrams per deciliter. Just as with calcium, the typical method of measurement for magnesium is colorimetric. Available dyes include calmagite, formazine dye, methylthymal blue, and Titan yellow. Atomic absorption spectrophotometry is the reference method. The major functions for magnesium include cofactor for ATP energy, cofactor or activator for many enzymes, over 300, major contributor to bone structure, and it plays a role in calcium absorption in the intestines. Hypomagnesemia often leads to hypocalcemia. Although PTH is more influenced by ionized calcium levels, it will be released when serum magnesium levels are low, causing increased intestinal absorption and increased kidney reabsorption. Aldosterone and thyroxine both lower serum magnesium levels by increasing excretion by the kidneys. Hypermagnesemia can be caused by renal failure due to a decrease in the glomerular filtration rate, or GFR, and hypoaldosteronism, Addison's disease, due to the fact that aldosterone stimulates sodium reabsorption while enhancing magnesium excretion. Other causes include increased intake of magnesium-based antacids, dehydration, resulting in a relative increase, and bone carcinoma. Symptoms include decreased neuromuscular irritability, cardiovascular and neurological symptoms, respiratory arrest, and paralysis. Hypomagnesemia can be caused by severe illness, most common in hospitalized patients, reduced intake, diet, deficient IV therapy, chronic alcoholism, decreased intestinal absorption, malabsorption, diarrhea, vomiting, increased excretion in the urine, hyperaldosteronism, hypoparathyroidism, and renal tubular disease, and during pregnancy and lactation. Symptoms include neuromuscular symptoms, tetany, and possibly arrhythmias. The anion gap is an indicator of the unmeasured ions. We measure some cations, like sodium and potassium, and some anions, like chloride and bicarbonate, but there are many others that are not measured. Under normal circumstances, the cations and anions must cancel each other. The usefulness of the anion gap is more to check that the results make sense. We should not have an abnormal anion gap if the patient doesn't have other symptoms related to acidosis or alkalosis. Most of the time, the anion gap indicates instrument problems or improper specimen collection. The calculation is performed by subtracting the anions from the measured cations and taking the difference. The difference between measured cations and the measured anions is equal to the difference between the unmeasured cations and the unmeasured anions. There are more measured cations than measured anions, so in order to cancel out, the unmeasured anions has to be larger than the unmeasured cations. Abnormal anion gaps are usually elevated due to an increase in unmeasured anions. Common causes include uremia, due to retention of sulfate and phosphate, ketoacidosis, resulting from starvation or diabetes mellitus, poisoning, such as ingestion of methanol, ethylene glycol, and salicylate, hypernatremia, and instrument error. Low anion gaps tend to be less common, with causes such as hypoalbuminemia, resulting in a decrease in unmeasured anions, and severe hypercalcemia, resulting in an increase in unmeasured cations.